Okay, good evening, everyone. Welcome to PCHF's webinar series. My name is Dr. Sama Akhtar, and I will be moderating today's webinar. Today, we are honored to welcome Bistra Zheleva. Bistra is the Vice President, Global Strategy and Advocacy, Childrens Heartlink. Childrens Heartlink is a global organization dedicated to improving access to high-quality healthcare to children around the world. In addition to this, she is one of the founding members of the Global Alliance for Rheumatic and Congenital Hearts and a board member of the One Heart Health. She is also a member of the steering committee of the International Quality Improvement Collaborative. Bistra has also authored and co-authored several publications for academic and non-academic audiences. She has an MBA in nonprofit management from the University of St. Thomas and has studied global health at the Harvard School of Public Health. Welcome, Bistra.
Thank you so much for the kind introduction, Dr. Akhtar. I am happy to be here and I'll share my screen. Today, I will be sharing about the organization I work for, which is Childrens Heartlink, and the approach that we have in developing capacity and supporting the development of pediatric cardiac programs in low resource settings. So I hope everyone can see my screen. When we talk about pediatric cardiac care and when we talk about the development of pediatric cardiac services, we gotta first start with thinking about what are the determinants of access to equitable pediatric cardiac services. So if our aim is here at the right, improved pediatric cardiac health through equitable access to pediatric cardiac care, we've identified that there are several determinants. One is availability. So you have to have a place where actually the treatment can happen. It has to be of high quality because this is highly specialized care and services. And so low quality often, unfortunately, means high mortality. It has to be affordable so families can afford to pay for the services and doesn't throw them into poverty. There has to be a general awareness about it, not only among the healthcare provider community, but also among the general public, because it's an invisible defect and sometimes it's not actually detected on time. And it has to be physically accessible. So families, again, do not have to travel too far. Often care involves long stays in hospitals, and that can actually mean loss of wages and poverty as well. In terms of congenital heart disease specifically, which is most of what I'm going to be focusing on today, is one piece about it is that since 1990, it has really grown in rank of as it contributes to mortality in infants. So as you can see here, in low middle income countries, it has come from number 7 as cause of mortality in infants to number 4. And in high middle income countries, it has come from number 2 to number 1 even in 2019. This is data from the Global Burden of Disease study at the Institute for Health Metrics and Evaluation at the University of Washington. And it's actually publicly accessible through their GBD Compare tool. Today, the data that they provide show us that there's about 217,000 deaths from congenital heart disease globally. There's about over 13 million people living with congenital heart disease in the world. And the losses in deaths cause about 18.6 million in disability adjusted life years. Unfortunately, most of the mortality is in low and middle income countries, and 70% of this mortality is in infants. So this is important data for us to know because it shows us where our interventions need to happen. And it's pretty much here in this category in terms of addressing infant mortality and avoiding those deaths. Again, comparing congenital heart diseases here as it contributes to infant mortality specifically, you can see that in high income countries is number 1, and globally it's number 4. So again, it's a very high ranking and unfortunately unaddressed. And we can't not talk about rheumatic heart disease as well. This is a chart that compares actually the impact of rheumatic heart disease and congenital heart disease. And we see that the dark gray here is rheumatic heart disease and the light gray is congenital heart anomalies. That congenital heart disease causes really, as we heard already, high death, high mortality in the infant and under 5 years, in the infancy and under 5 years, while a rheumatic heart disease causes mortality later in the 20s to 50s. However, it's kind of this longer tail of disability that people have to live with versus the high mortality in young years. And this is important because these two diseases both have an onset in childhood, and they more or less actually use the same services, can be using the same services. So when we're talking about development of pediatric cardiac services, it's important to look at both of these diseases because we can make a better investment argument with whoever that audience is, that stakeholder is, whether it's government or hospital administration. And here's again another argument of why this is a good investment. The essential surgery volume of the disease control priorities volumes published in 2015, they compared actually the burden that could be averted by scaling up selected subspecialty surgical care in low and middle income countries. And they found that, again, same to what I just said earlier, that scaling up congenital heart services, so building more surgical care specifically for that, for this disease, can actually avert the most deaths among these other pediatric subspecialties. So, about Childrens Heartlink, who we are. Our vision is that children around the world would have access to high quality heart care. Mission is that we save children's lives by transforming pediatric heart care in underserved parts of the world. And we have 3 streams of work. One is advocacy. The second one is hospital capacity. And the third one is helping build patient care pathways. Most of the work that we do is actually here in the middle. And this work in terms of developing patient care pathways for referrals of patients on time has really been developed in the last 5-6 years, as well as our advocacy that has been developed, more fully developed in the last 2-3 years. We are over 50 years old. We started by bringing children to the United States for surgery 52 years ago. We had a period where we were doing medical missions. And since early 2000s, we started focusing on capacity building. And as I said, in 2017, we really tried to expand our model to include this regional and country level strategy as well as advocacy. So I'll probably spend most time talking about our hospital capacity building work. Excuse me. In terms of how we build capacity for quality cardiac care is that we actually choose hospitals that have pediatric cardiac programs and work with them through this phased model, hoping that they will become a Children's Heartlink Center of Excellence. The phased model involves 3 phases, and our capacity building support and activities focus on these 4 areas. Certainly, and most importantly, building their clinical capacity, building their organizational capacity. So the hospitals and the pediatric cardiac programs actually are set up for for sustainability and for future growth, building their training capacity, because we do through this training, do go through a certain selection process. We look at partner hospitals that are already active, and we do a lot of discussions with them at the very beginning, even prior to the partnership, to understand that whether we have our values actually match and whether we can continue this partnership. So our guiding principles are really focusing on saving the lives of children, which is our #1 goal. We really put a high importance on quality care and multidisciplinary approach, which both of which are key to excellent outcomes in pediatric cardiac services, which really leads to the value of starting with the scale in mind of where we want to be in 10 years, that we want them to become a center of excellence that provides excellent care. We choose committed leaders, and that means that we actually look for these champions that we can be supporting. We try to understand the context very well in which our partner hospital works. We are very collaborative, and our approach is really not prescriptive. We don't come with specific predetermined ideas in mind, and we listen a lot to our partners' problems are and challenges are, and try to address them together with them and the medical volunteers, which really builds a lot of trust in our partnerships. And our partnerships are long-term. It takes about 6 to 10 years actually to develop a center of excellence. It really takes a long time. So we pace ourselves and don't try to achieve everything at the very beginning, because the challenges that we try to overcome are pretty big. Our capacity building is tailored to the needs of our partners, and we're very much committed to tracking progress and impact, which really builds ownership at the partner side level, and we all keep learning together. Again, a lot of detail in terms of what our motto is for building sustainable centers and through the different phases through year 1 through 10. But when we look at a center of excellence, we really want them to have low morbidity and mortality outcomes. We want them to see an increased volume in the terms of the numbers of patients that they treat. We want to see evidence of multidisciplinary team approach, and for them to be a research and knowledge leader, as well as being a regional trainer. And I want to emphasize here the pediatric cardiac multidisciplinary team. It is probably one of the key things that unfortunately gets most overlooked. People like to think about surgery, and they're extremely important. Without a surgeon, you cannot treat children, you cannot provide care. But the point of this graph here is to show that in order to treat one little child, one little baby's heart, you have to have all of these specialties, subspecialties and disciplines working together in tandem to provide the best possible care. It's complex and it takes a lot of different people, but it is possible. We've seen it happen in low income countries as well as in high income countries. And it's probably one of the biggest determinant of high quality outcomes. Our partner, we work in 5 countries. They're Brazil, China, India, Malaysia, and Vietnam. And we have 18 partner hospitals today among those countries, 5 of which with one very soon becoming center of excellence. So hopefully 6 of them will be centers of excellence. And these are some of the volunteer institutions that we've partnered with, and we are recruiting new partner institutions as well right now. A key component of our work is our partnership with the International Quality Improvement Collaborative for Congenital Heart Disease, which is run by through Boston Children's Hospital, led by Dr. Kathy Jenkins. That the IQIC is a data registry, as well as an opportunity to offer quality improvement strategies to reduce mortality and major complications for children undergoing congenital heart surgery, and also builds the global community of centers. So today we have actively 64 sites in 27 countries, and we've entered over 130,000 surgical cases in the database, as well as I think over 2,500 cath cases in the cath database. But the IQIC is key because it gives organizations like ours the data that we need to be working more effectively with our partner hospitals to help them improve their outcomes. So next I'll talk a little bit about our advocacy activities. And we cannot talk about advocacy without placing the goals that we have within the Sustainable Development Goals, and specifically goal number 3, good health and well-being, which has a number of targets. I'm not going to read them, but it's really reducing mortality in children, reducing mortality from non-communicable diseases, which heart diseases in children are, achieving universal health coverage, which really talks about financial risk protections or protection for families who have to pay for this care, so they don't have to actually, and substantially increasing health workforce in low and middle income countries, which is together with the financial aspect is really one of the biggest barriers. We do not have sufficient number of doctors or centers, and they're not being trained right now, not being prepared to address the burden that we saw earlier in my presentation. Of course, there are other areas that we could cover, like the no poverty goal, again, related to the financial risk protection, as well as several others, quality education and gender equality. Again, going to our determinants of access of pediatric cardiac care, this should drive any advocacy activities. And in addition, I think what complicates congenital heart disease specifically is that it's not preventable, or at least largely not preventable. It's highly complex as well as expensive. So these are things that we have to keep in mind when we're advocating for additional investment. So we really are trying to build a population approach to congenital heart disease. And I have a couple of examples here of what Childrens Heartlink has done in the past. One is in the state of Kerala, which is in the south of India, and the other one is in the country of Malaysia. And so these are both started as advocacy activities, but one grew into what I called earlier the patient referral model. So in Kerala, and in Malaysia, both actually had similar lower and lowering mortality, infant mortality and under 5 mortality. But the goals of the state and the country in Kerala was really to reduce it further in accordance with the Sustainable Development Goals. While in Malaysia, the interest of the government was to build more pediatric cardiac services in the public sector, to build reliance, to reduce reliance on private providers, and to plan for regional provision of tertiary care for congenital heart disease. So very similar in a way, but in terms of how they look, but a little bit different goals, because Kerala actually had sufficient number of centers. And so both of them actually found that congenital anomalies, of which congenital heart disease is the largest, had the highest contribution to infant mortality in both regions. And in Kerala, we actually got involved in developing this pediatric cardiac care continuum. And we really worked closely with the government in a technical assistance role to achieve their goal of building capacity in almost all of these areas, domains. So kids or babies born with congenital heart defects get referred on time to treatment. And today they've really had quite a success with the development of a regional database, of a state level database, registering every child born with a congenital heart defect in terms of from newborn screening as well as prenatal screening. Their referral pathways are excellent and followed by most clinicians in the state. And they're starting to actually improve their follow-up care as well. So in terms of what our advocacy goals as an organization are, is that our #1 goal is really to get governments to invest and improve access to health services for children with heart disease. And we also get involved in improving clinical practices and guidelines at national and global level. Again, a lot of details, but I just want to show that when we try to engage in advocacy, it's subnational, which is like Kerala, when it started, was an advocacy effort, at a national level, which is at a country level, more like what we do in Malaysia, and global advocacy, which is a little more diluted, but it's something that we try to get involved with, is with multinational agencies that set guidelines, global guidelines for pediatric services. Some of the opportunities that we have not fully explored is partnering with patient and family groups, such as the Global Alliance for Rheumatic and Congenital Hearts. It's an excellent organization that is advocating on behalf of both people with congenital and rheumatic heart disease, as we call it, childhood onset heart disease. Opportunities for advocacy with other NGOs. professional societies in countries where we work, as well as advocacy with multilateral organizations and donors, like I mentioned. This is one example of our advocacy materials that we developed, which is the Invisible Child series. If you have not read it, you can go on the website down here and download the 4 policy briefs. We have the 4 policy briefs, their titles are up here. And in the last one, Call to Action, we actually called for 4 changes globally with actually specific calls to different actors on what they should be doing. One was increasing capacity to care for children. Then it was building a pediatric cardiac workforce, closing the data gap, and improving financing for pediatric cardiac care. This is one example that actually a number of people from Pakistan were involved with, which was the development of a global standard of value-based care measurement set for congenital heart disease through ICHOM, through the International Consortium for Health Outcomes Measurements. Childrens Heartlink had a role as one of the sponsoring organizations, and it's a tool that we actually will be trying to promote with different programs around the world to use. And last, I just want to show that this is another framework that we developed that is actually can be very useful when we talk about advocacy, which we call the Population Health Framework for Heart Disease in Children. And it's based on the social and behavior theories, basically, and it's the so-called social ecological model, where there's different levels at which one can be advocating to change what and what actor need to be engaged to make those changes. And this advocacy can be done by organizations like ours, by patient and family organizations, by different individuals involved in this. So last, I just want to show a couple of slides that show actually where congenital heart disease is. I spoke a lot about infant mortality, is specifically in Pakistan based on the Institute for Health Metrics and Evaluation Global Burden of Disease data. And so we can see that actually has not changed that much in terms of rank and contribution to infant mortality. Since 1990, it's went up by 1 spot from 8th to 7th. When we compare it to other countries in the region, and I chose kind of randomly, Bangladesh, Iran, China, and India, we can see that it's still lower in the ranking comparing to those other countries. And what this means that there's probably still a fair bit mortality that happens from these other preventable causes, which most of these other countries have been addressing. I also suspect that in Pakistan, there's a fair bit regional differences. And so that might be one way to address congenital heart disease as well in the country. And I want to say shukriya and thank you for the opportunity.
Thank you very much, Bistra. That was such an informative and elaborate webinar, and I have learned so much in just 25 minutes. And it's amazing because as an organization, you feel that it's just you. You're the only one out there, you're alone. And it's amazing to see how much work Childrens Heartlink has accomplished in a short amount of time. And it's just about applicability of that work to low resource settings. So thank you once again. Now let's move on to questions. The first question is actually pertaining to your first slide about the determinants over which you base your interventions or initiatives. And the question is that which of these determinants poses the most problem or challenges? Is it the lack of awareness amongst the community, screening, access, or low resources?
That's a great question. And unfortunately, I don't know the answer. It's probably different in many different places because we work in some countries where there's fairly good awareness about the disease, but there's not enough investment. So I wouldn't say the lack of awareness is the number one. Probably the number one cause, if I have to guess, is financing, is the lack of appropriate financing. because with that comes, if you don't have sufficient financing, with that comes lack of sufficient training for people and development of centers where people, where children can receive care.
Right. Okay. So the next question is that Childrens Heartlink is based in the U.S. So how do you connect where you are based, which is a high-income country, to LMICs? Do you? Sorry. Hello. I'm sorry about that. Again, IT issues. Again, sorry. I would like to repeat the question. The Childrens Heartlink, it's based in the US, which is a high-income country. So how do you connect where you are based to LMICs? Like you mentioned, multidisciplinary teams and capacity building. Do you send teams from the US, or do you, how do you do capacity building locally in LMICs? Do you use local resources that are already available to them, or do you mobilize them from the US?
So we do two things. The first is when we select a partner, we match them with a volunteer institution. And so the volunteer institution, typically from the United States, but we have volunteers in other countries as well. They provide all the training and education, and our organization organizes, sponsors exchanges between those two institutions. So not only teams go to our partner hospital in one of those countries, but we also send our staff from our hospital partners to the volunteer institution whenever needed and appropriate. Three things. The second thing is really we connect them with the IQIC and make sure that they can use actually those resources very well in terms of measurements, outcomes, but also the learning part and the quality improvement part of the IQIC. We try to leverage that as much as possible. And the last thing is, once a pediatric cardiac center becomes a center of excellence, a Childrens Heartlink Center of Excellence, they are actually a very good resource for us in that country. And we use them very closely when we work with new partner institutions and when we try to develop new hospitals. That is one of the reasons why actually we have not expanded into new countries recently. In the last, I would say probably 8 to 10 years, we have not started partnerships in new countries, because we realize that, first of all, in the countries where we work, there's still a lot of need and we can be doing more. And we leverage the already existing centers and centers of excellence we have there. We leverage their expertise now to provide training domestically. They never serve like the same way our US volunteer teams serve, but they're an incredible resource. And so many of you maybe have heard about a hospital in India, which is Amrita Institute of Medical Sciences. They're a tremendous leader and partner for us. In Brazil, our longest partnership there has been 10 years. That partner will become a center of excellence this year, will be named one of them. And so they're a great resource in the country as well, and developing new training initiatives and new training programs locally for the country. So this is one of the strategies that we have in selecting centers that can become centers of excellence.
Okay, so off of that question, there is another question. Like you mentioned that you select centers that could be possible centers of excellence that fulfill your criteria. What if an institution would like to take an initiative on their own? Because obviously lack of awareness is on both sides. There is lack of exposure of nonprofits within, for example, Pakistan that are doing work on congenital heart diseases. So how can such an organization contact you, or is it possible for them to be a part of your initiative and program if they contact you rather than the other way around?
Yeah, that's a great question. I wish we have the capacity to work with other organizations, with other countries. For us, we're a nonprofit organization and it's all about funding availability. And so when we do have funding availability, we do consider new partnerships in new countries. I still encourage people to contact us and to get in touch with me. My email was on the last slide. Certainly we want to discuss and have a lineup of potential opportunities, but we gotta be selective, unfortunately, because of our resource limitations.
Particularly now because of COVID-19. So that is actually my next question. How has COVID-19 affected Childrens Heartlink?
Yes, it's affected us very much, just like anybody else. I mean, as you can see, we rely on face-to-face, in-person exchanges, training exchanges between our partner hospitals and their volunteer institutions. And that has changed. No one can travel. And so I don't lead that work, but my colleagues who work on that part of our hospital capacity building, they have been really actively engaging with remote education and remote training. We know the pandemic will end eventually, and we will get back to our face-to-face training. This is intrinsic part of our work, and it's something that we will not abandon, because as a subspecialty service, this does need bedside training and bedside education. It needs people to be together at a hospital to learn. And so this will continue, but we are developing what we call a blended model, where the blended model will involve actually a lot of exchanges between the partner sites and the volunteer institutions in between the training face-to-face in-person meetings.
That's wonderful to hear. Of course, this is the time to not give up. And I'm pretty sure there people can benefit a lot from your slides itself. They're so informative, and people who feel that they cannot have a face-to-face learning experience from teams or from medical missions. Everything is online, and we are really grateful to you for such wonderful, informative slides, and of course your talk. So before we have time for one more question. You mentioned the selection of your centers of excellence. So could you please tell me a little about the monitoring or surveillance of these centers of excellence in the future to offer sustainability to the CHD healthcare setup within that country?
Yes, so this is where the IQIC plays a very important role as a partner for us. The data that they collect, they don't collect, but the data that the centers input into the IQIC database, IQIC produces reports to each participating center. And so we have an agreement with both the IQIC and our partner hospital to also see those reports. And so those, the reports, I believe the PCHF is actually familiar with them, but they do cover information about mortality, morbidity, distribution of types of cases, complexity, obviously, and age distribution. And this really, the reports serve as basis for tracking of progress. It's not a policing effort. The sites are independent entities. We are just partnering with them to help them improve. But it is an important aspect of seeing what outcomes are and to point out in what area they will need improvement, because they might want to improve care in specific types of surgeries that they provide, specific types of patients, and the IQIC definitely gives that information. We also actually collect additional, annually we collect additional information from our partner hospitals that they provide to us independently. So this is part of our partnership agreement, is the data sharing. And I want to stress that this is purely between us and them and the volunteer institution they work with, because without that trust that I was talking about of sharing outcomes and sharing the data, improvement can't happen.
Definitely, and transparency is an issue that we face over here as well. But transparency, it does increase credibility. So I understand where this point is coming from. Okay, so we have one question from one of our panelists. Does your initiative offer follow-up care and counseling for lifelong care, for example, for adult CHD patients?
Whenever a partner institution we work with, whenever they have a need to develop that services, we would support them. The focus, the bigger focus for our organization is developing the pediatric services. But if partner sites have an interest and have staff to dedicate to developing adult congenital heart disease service, we will support them. The unfortunate situation is that many of the countries and many of the hospitals we work with actually don't have that ability. They either do not have sufficient number of cardiologists, or they just do not have necessarily the staff. But it is an important aspect, and we try to stress it. I would say many of our partner hospitals have expressed interest, and maybe at least couple have received additional training and kind of try to develop it as a separate service line.
Okay, I'm sorry, but there's one more question from one of our viewers. The question is, how do I get the government to be more involved in my organization?
Well, it depends on what kind of organization we're talking about. So I'm not sure where that the person is coming from. Is it a hospital or is it an NGO?
It's a nonprofit, which is not primarily dealing with congenital heart diseases, but pediatric cardiac surgery.
Sure. Okay. Well, that's where I talked about in the parts where I mentioned advocacy. I think first we have to learn what are the government's priorities in terms of healthcare, and what are the priorities in terms of specifically addressing healthcare for children. Pretty much every country around the world has signed on to the Sustainable Development Goals, and those are very explicit in wanting to reduce childhood mortality. So my experience shows me that actually every country has some sort of a plan where they say we're going to reduce it by X. And many people don't know about these plans. So finding out what are the government's priorities and finding those commitments that they've made and holding them to accountable to those commitments. I know it sounds very easy for me to say, but it does take a little bit of effort to find the people who are responsible for specifically around childhood health priorities at the Ministry of Health. Often people have to actually communicate with the Ministry of Education when we try to advocate for additional training of the health workforce. One thing that we are finding, and we by no means, actually my organization does not have an experience with that, is engaging the Ministry of Finance, where they actually have to be also made aware of these needs and of the need of additional investment. Because often the first thing many governments say is there isn't enough money, our budgets are small, which is true, but with good planning and with good awareness building and kind of consistent educating of the policymakers, there are changes that can happen. And of course, another great opportunity is, we've talked about this in the patient and family community, is activism, which is really engaging the patient and family community to advocate and involving them as partners to advocate for these services. But I would say finding what the priorities are, finding the right people that need to be educated, and finding the right messenger, which can be the patient and family community.
Okay, thank you for that. And we have one question actually from Africa. The question is, we are in a region of where the situation is unpredictable. So how do you bounce back from an unsuccessful program or a program that has been disruptive because of conflict? So I'm not sure. Yeah,
I don't have experience in working in humanitarian settings, unfortunately, and so one piece about what I'm just thinking how to best respond to this question. So our organization does not get involved in, again, limited resources. We had to make choices, but we do not get involved in areas with unstable political and social situations. And so we do not have experience working in humanitarian settings. There are organizations that, that work in those settings. And one comes to mind is the Novic Cardiac Alliance that has worked in a number of different countries in the Middle East and in Northern Africa. And I actually would like to think that the advocacy is probably very much similar, finding priorities, finding the right people, and finding, how to talk to these, the right people. But in terms of investing in pediatric cardiac services, I know it's probably going to be harder because they may need to more investments to rebuild even just basic primary healthcare service. So unfortunately, I'm not the right person to answer this question, but that's kind of the best that I can come up with. I don't have this experience.
No, but thank you for highlighting the Novic Alliance's work in Africa. I think that should help a lot. And that does actually conclude our questions and answer part of the webinar. And again, Bistra, we cannot thank you enough for being part of PCHF's initiative for advocacy and awareness on congenital heart diseases. And we, all of us have learned a lot. And we hope to see you again in future PCHF endeavors. So any concluding words, please?
Thank you so much for this opportunity, and congratulations to PCHF for the great work that you're doing in Pakistan. I think you're really setting an example for many different organizations around the world of what can be done. And there's a lot of respect globally for your work. So I appreciate the opportunity to speak to your audience.
You're too kind. We are absolutely humbled. And here's wishing you a good day. So take care then.
You too.
And thank you to all our panelists, to all our viewers, and looking forward to seeing you in our next webinar. Take care, everyone. Bye-bye.
Bye-bye.